Hi everybody, I'm Dr. Deed Harrison. I am president of Chiropractic BioPhysics Seminars and Technique and president of Chiropractic BioPhysics Nonprofit, a spine research foundation. This week we're going to go through our video research review for one of the CBP nonprofit publications. This is video number 35. This comes from Spine in 2004. So the title of the paper is Modeling of the Sagittal Cervical Spine as a Method to Discriminate Hypo-lardosis. Results of elliptical and circular modeling in 72 asymptomatic subjects, 52 acute neck pain subjects, and 70 chronic neck pain subjects. Lead author was my late father, Dr. Don Harrison, myself, Deed Harrison, my dad's PhD advisor in mathematics, Dr. Tad Yannick, Dr. Renee Caillet, MD, from University of Southern California, USC, Dr. Joe Ferrantelli, Dr. Jason Haas, and then the late Dr. Bert Holland, PhD in statistics formerly from Temple University. This was in Spine 2004, volume 29, issue number 22, page 2485 through 2492. So last week we talked about a similar project, but this one in fact is a little bit more sophisticated in terms of it's not just making angular measurements on x-ray, it's physically modeling the shape of the cervical curvature as a method to see if we can identify differences in different populations of neck pain versus a normal population. So the idea is, what is a normal cervical curve? This is a very, very big issue. You can't answer this with just one project, but what we can do is we can fill in gaps. We can discover innovative ideas and concepts on what is closer to a normal alignment for the sagittal cervical curve. Now shown here is the convenience of two x-rays. On the reading left, certainly one that would be considered abnormal in the shape of its alignment on the back of the vertebral body margins outlined in this red dashed line from C2 to C7, compared to the green idealized cervical curvature, which is actually shown on the reading right, the x-ray described as normal. You know, you can see that this has a much smoother geometric shape on the back of the vertebral bodies. You can see clear disc spaces and nice sized disc spaces between the vertebra. And over here we can see the disc spaces are degenerative or degenerated and really destroyed, right? And then we would classify this one on the left as having extreme, severe spinal arthritis and disc degeneration. This one would be considered normal aging, and there's really no disc degeneration, no bone spurs, etc. So this particular paper, I'm not going to give you an introduction other than what I just showed. We're just going to dive into the methods because that's really the most important part of the project, what we actually did that's unique in this paper. So we took three groups of subjects. Group number one was a convenient sample of normal subjects that we really rigorously defined in terms of how much anterior head translation we were going to allow. So one of the problems with looking at normal cervical curvature, you can't include things that also would correlate to or contribute to pain. For example, forward head translation. If somebody's head goes forward from the side, that postural position has been shown to contribute to and correlate to neck pain and headaches. So we don't want that in a population of normal subjects, and we don't want that in a population of symptomatic subjects when we're trying to look at, are there group differences in the cervical curve? So for our normal subjects, we really narrowed down and said, what is a normal range for anterior head translation? And we chose 10 millimeters as the cut point for normal subjects. We're going to let you go up to about 10 millimeters of forward head translation, and if you're above that, you're not going to be in the project. So it says normal subjects with less than or equal to 10 millimeters of forward head translation. These subjects had no symptoms of head and neck complaints, no scapular complaints, no arm complaints, etc. We then took a group of 52 acute neck pain subjects, defined as subjects who had pain less than 6 weeks in duration. So these were an acute neck pain, but not an acute traumatic injured population. So these were not motor vehicle crash collision subjects. These were subjects that just, had some kind of mild sprain strain mechanism of injury, and they have neck pain. They have no arm pain, right? But they have neck pain, suboccipital headache, no pain below the shoulder, right? These subjects, we said, we're going to include subjects with less than 25 millimeters of forward head translation, right? It's very difficult to get neck pain subjects that have, less than 25 millimeters of head translation, so this is what we chose. Most people with neck pain classically come in with at least an inch of head translation, so trying to identify pain subjects with less than 10 millimeters of forward head translation wasn't really possible for us in this project. So we've got 52 acute neck pain subjects, less than 1 inch of head translation. Then we have 70 chronic neck pain subjects with also less than 25 millimeters or 1 inch of head translation. Chronic pain is defined as more than their first occurrence of neck pain, requiring intervention, and or symptoms lasting greater than 12 weeks or 3 months in duration. Now, for all of the subjects, we have to have an exclusion criteria that's more narrow. We talked about the head posture, but we also, in this case, we're trying to look at what is the definition, if we can find it, of a normal cervical curvature. We don't want to include subjects that have kyphotic necks or S curves. Any type of segmental or total kyphosis or any type of true straight neck we don't want in our population. Now, if you're watching this series and you saw last week, video number 34, we included subjects that had kyphotic necks and straight necks in that population. Here, we're excluding that in all 3 of our subjects. The normal subjects, the acute pain, the chronic neck pain, none of the subjects have any segmental, any total kyphosis in their neck, and none of them have a true straight neck. Only lordotic neck subjects are included in this population. This is one of the unique features of this project. We are only looking at true lordotic necks in each of our 3 populations. Also, significant spine degenerative joint disease. We don't want that in our population. That can also contribute to, or cause in some cases, neck pain in people. So we have no, overt degenerative joint disease in our population. Now, they might have mild, but they don't have moderate to severe degenerative joint changes, right? Also, no instabilities. So if you truly have an instability on your spine x-ray, you're not in our population. Any anomalies, any fractures, and then any history of a recent trauma, you're not in this study, okay? So this is a relatively narrow group in terms of our 3 subjects. So the curve types that we excluded would be this one up here. If you have more than an inch of anterior head translation, you're excluded from our population. And that's measured from the back of the articular pillar of C1 relative to the back of the body of T1. Okay? Also, necks that are straight up and down, like this one here on the lower left, where the arrow is, that type of neck curve is not included in our population. That's a straight neck. A true reverse cervical curve is not included. Any type of S curve where the lower neck is flexed and the upper neck is extended is not included in our population. And then conversely, if my upper neck is flexed and my lower neck is extended, that's not included. The ones on the bottom, these are truly abnormal necks. We've been talking about this a lot in this video series. If you watch video number 1 all the way up to number 35 here, you'll see that we've put out many papers that establish the fact that these types of neck curves are more common in people that have complaints or problems or a condition. Therefore, we're going to classify them as abnormal. We're not going to include them in a population where we're seeking to understand what a normal cervical curvature is. Now, if you don't like that as part of the methods, Too bad. That's what we did. Every project has exclusion and inclusion criteria. And the better you narrow your groups down, the more realistic the application or interpretation of your findings will be. Okay, now you might want to debate this, that these lower necks are normal, but we're going to say they're abnormal. They're not part of our study. What we're going to include then is quote-unquote normal types of necks that range from some kind of a flattened curve, it's still got some amount of curvature, all the way up to, too much curve to what we would call the perfect curve, whatever that might be, right? So these are the curves, or those were the curves that were excluded versus included. Now the X-ray measurements in this project. We've already talked about the Chiropractic BioPhysics posterior body tangent lines. Just to review, these are the measurements we used. The relative rotation angles, or segmental angles, these are what give rise to the total angle of curve that we call the absolute rotation angle, or ARA. So we measure all these segmental angles using the back of the vertebral bodies to look at segmental angulation. For example, these two lines on the back of 6 and 7 in my lower neck, that gives me the segmental angle from C6 to C7. Here's 5-6, here's 4-5, here's 3-4, here's C2, C3. These angles add up to the total angle. We've measured both of them in this particular project. By both, I mean the segmental angles and the total angle of curvature. So we chose the total angle of curve from C2 to C7. We also looked at head translation. We did C1 to T1, and we also did C2 to C7. How far is the posterior superior body corner of C2 relative horizontally to a vertical line that comes up from the posterior inferior body corner of C7? That horizontal distance is anterior head translation. Normal subjects had less than 10 millimeters or up to 10 millimeters, and the abnormal subjects were allowed to have up to 24 millimeters. Okay? Also in this project, this is one of the most important parts of the project, we actually included modeling of these subject spines. We had coordinates, X and Y coordinates, two-dimensionally, that we input into a computer system, and we looked at geometric curvatures in the cervical sagittal plane on how those were able to fit the amount and shape of the cervical curve. We looked at circular modeling and elliptical modeling. I'm going to skip the equations, but the equations are very detailed in the paper. So we passed curves through the posterior vertebral body margins from C2 all the way down to T1. And we wanted to identify, can a piece of a circle, a circular geometric shape, model the path of the cervical curve in the sagittal plane, or is it more elliptical, or is it something else? And then we wanted to look at the normal subjects models versus the acute and the chronic subjects models. So we're actually looking at a couple things. If it's a circle, we're going to take the height divided by the length, and we're going to get a ratio of that. And then we're going to look at its radius of curvature. So we're going to look at R as the radius. Now, radius is an important variable, but it's only important, or you can only use it if the subjects are matched for height. So the subjects have to be matched for height if I'm going to use the radius of curvature. Obviously, a shorter person versus a taller person with the same angle of curve can have a different radius of curve, right? This is where the height over length ratio comes into play. So we're going to look at the ratio of the height of the column, T1 to C2, or C2 to C7, or we could look at C1 to T1, different parts of it, its height versus its length along the curvature, and we're going to get a ratio there. Now, if it's an ellipse, which is a circle is a special type of ellipse. An ellipse has what's called a short axis and a long axis. We make a ratio called B over A. You could also do the height over length ratio of an ellipse, but we're really interested in the elliptical ratio. Instead of the radius of curvature in a circle, B over A equals 1, we call it the radius. But in an ellipse, we have a short axis, and divided that in by the long axis, we get a B over A ratio. So these are our modeling ideas that we're going to look at. And again, I'm skipping the equations just for simplicity. It is actually graduate level mathematics with those equations. So if you're not above a master's degree in either mechanical engineering or mathematics, good luck following that. And I'm not, so I'll skip those equations. These are the types of pain subjects that we included in our population. We allowed people to have, posterior lateral type of head pain, which is coming from the upper neck joints, by the way. Even though you feel it in your skull, the source of pain is actually in the upper neck joints, between skull and atlas and C2, and even C2 and C3. And we allowed pain all the way down into the mid-thoracic area, scapular region, shoulder region. These are the types of neck complaints that we allowed in the population. Obviously, the normal subjects did not have complaints, so that was regarding the acute and chronic neck pain subjects. Now, this is just group variations in age, weight, height, sex, and then their pain scale. So looking at this, here's my normal subjects up here, and I know the table's a little small, but you should be able to see it. 72 normal subjects. We had 36 men, 36 women. Their average age was just over 40 with a standard deviation of 10. Their height is 170 centimeters. Their weight is 76.6 kilograms, and they have no pain. They're actually a 0 out of 10 on a visual analog or numerical rating scale. Here's our acute pain. 21 female, 31 men, 34 years of age. So right away you can see that they're a little bit younger in terms of the age. 172.6 centimeters in height, no statistically significant differences, and then 79.8 kilograms. And then the pain scale is a 3.1. And then our chronic pain, male to female ratio, 32 to 38, 44 years of age, 172 centimeters height, 78 kilograms, 4 out of 10 in their pain. This is moderate chronic pain. Now, if you look, where is the statistically significant differences? Well, it's in the age. We have statistically significant differences in the age, but the other variables were quite matched, right? There's no statistically significant differences for height and for weight, and then for the male-female ratio. Of course, there's differences in the pain because our normal subjects are asymptomatic, and then we have acute and chronic neck pain subjects. So why is this important? Well, I said we need our subjects matched for height when we look at our circular modeling or some of our elliptical modeling results that just use a single variable, right? So the subjects are matched for sex, height, and weight, but not for age. And quite frankly, they're not that far off in age either. We can still make approximations and comparisons. And the bigger issue is this. Chronic neck pain is likely more serious than acute neck pain, and they're very closely, matched to our normal subjects. So that's maybe perhaps the most profound issue. Comparison of group measurements. I'm not going to read all these to you, but what I would like you to just note is over here the statistically significant differences between chronic, acute, and normal subjects in their segmental angles, the total angles, their height over length index, and then I'll show some of the other modeling things coming up. So if we look at the height over length index, 0.97 or 97%. 1.0 is a perfectly straight cervical curve. So 97%, what does that translate to? Well, that translates to an ARA C2 to C7 of 34.5 degrees. That's quite a nice cervical curve. And if you look at the segmental contribution to the curve, it's very uniform. Its segmental contribution to the curve, everything is 6 degrees except right at C6, C7. It's very, very close, right? And if you look then at the acute neck pain subjects, you'll see reductions in those. The chronic neck pain subjects, more reduction. So look at this. Acute neck pain, 0.975 in its height over length ratio, 0.98. Now you go, oh, indeed, that's only 1% different. Well, let's go up to the ARA. Look at the ARA C2 to C7, 22 degrees versus 34.5. That is very statistically significantly different, right? P less than 0.001, right? So that's a 12-degree difference in our curvature. And also, I want you to look at the standard deviation. Always, pain subjects have a larger standard deviation of their measurements than normal subjects. Normal subjects should be, if we classified them right, they should be tighter around the mean. Chronic pain subjects, because there's no such thing as a perfect dichotomous variable between groups, there's going to be a broader distribution. And I'll talk about that statement coming up so it makes more sense. Okay? There's never a perfect dichotomous variable, but what we're looking at, is it good? Can we use it, right? In other words, there are a variety of reasons for people to have chronic neck pain, not just because their cervical curve is too little or too much, right? So I'll get back to that statement, which seems a little contradictory. But what I want you to note is that the segmental angles that are really off are really in the mid-cervical spine, as well as their total angle of curvature. And then, of course, the height over length ratios are different. In fact, most of the variables are different, except for C6 to C7 and the C2 to C3 angle. All right, this blows up the main findings. This is the total angle of curve between normal, acute, and chronic. Look at the C2 to C7 angle, which is the one we use in chiropractic biophysics. 34.5 degrees for normal, 28.6 for acute pain, 22 for chronic. These are statistically significant differences, right? Cobb angles are different. Now, I do want you to note one thing. Notice in the same subjects, we go from a 34-degree curve down to a 26-degree curve just by using a different measurement. This is important. Now, Cobb angles at C2 to C7, depending on the study you look at, are anywhere from 9 to 15 degrees less than the ARA. So I've oftentimes, debated with people, and they go, "Oh, your data is way off. Your data in CBP, it shows curves that are in the 30s, and other studies are in the 20s." It has to do with the way they make the measurement. Come on. You have to compare apples to apples. You can't compare an apple to a watermelon. Even though it's the same vertebral levels, it's a different measurement. Cobb angles are a cross-section through a curve. They do not represent the actual curve of a column. Anybody out there that had calculus realizes that calculus, we calculate the slope of a curve by looking at its first derivative of a line that's tangent to the curve at any point. It's called the first derivative. That equals the slope of the curved column at that point. Cobb angles are not slopes. They're not. They're cross sections through end plates. What that means is, if I look at the back of the body of, let's say, C2, and I look at the vertebral end plate, the lower part of the vertebra, it's not going to be 90 degrees to the back of the body. It's tilted down like this, 10 to 15 degrees. So it reduces the cervical curve as an artifact of the measurement. So look at this. It's the same people we're measuring, and their curve's 9 degrees different. Okay, hopefully I didn't go off on too much of a tangent, pun intended there, right? Now look at this. Here's my acute neck pain subjects. 28.6. Look at the Cobb angle here. Same subjects. It's 12 degrees less, right? Remember, I told you it depends on the population you're looking at. It's anywhere from 9 to 15 degrees different, right? So these are statistically significant differences. Let's jump down here. This is really important. We've matched our subjects for height, so we know the height over length ratios are different. But then we notice the circular models are also statistically different. I can use the radius of curve now that I know that the subjects are matched for height. So look at the radius of curve in the normal subjects, 132.8 millimeters. Look at the acute neck pain and look at the chronic neck pain. The chronic neck pain's radius is really stretched out. That means a flattened cervical or a circular type of curve. It's really approaching a much more linear pattern. This is strong differences between the groups. So here's the idea. This is what we were able to do with curve fitting techniques using what's called the least squares error approximation approach. This is the back of the vertebral body at C2. This is the superior body. This is the inferior body. Right here between the two diamonds is the disc space between C2 and C3. I hope you can see that on the screen. Here's C3 body, that diamond. That's the superior, that's the inferior. Then the disc between C3 and C4. And then we go all the way down till we get to T1, thoracic vertebra number 1. That's where my first ribs are. That's my upper shoulder area. Back of the body of T1, superior and inferior down here. And then the disc space between them. Now what we did is we were able to curve fit using what's called a least squares error approximation through this data set, through these points. We are able to fit C2 to C7 of our subjects with different ellipses. So here's an ellipse. Here's the long axis, and then here's the short axis. We call it the semi-major and the semi-minor axis, right? So here's my major axis, here's my minor axis. Here's a different ellipse. It's rotated backwards, tilted backwards. This one has a different B over A ratio. Here's another ellipse. It's rotated even further backwards in space. We were able to fit C2 to C7 with several different types of ellipses if we just tilted them in space and we changed the orientation of where their short axis and long axis passed relative to the cervical spine. We also were able to change the B over A ratio and get those to fit as well. However, when we included thoracic vertebra number 1, T1, the only geometric shape that was able to fit down to T1 was a circle. So follow this bold circle here. It passes through C2, C3, 4, 5, 6, 7, and it fits T1, whereas right in here, if you look at these ellipses, it's kind of hard to see, but you can see the ellipses don't actually fit the thoracic vertebral body. They diverge away. This is really important. T1, part of it is actually part of the cervical spine. If you look at its anatomy, like the upper half of T1 vertebra has really similar features to the neck vertebra. The lower half of the thoracic vertebra has features that are similar to the thoracic spine. Hence, it's the inflection point between the two curves. It's a transitional point. Therefore, we looked at this and we said, this is very important. The circle is the only geometric shape that physically fits the entire cervical spine, including T1. Right? This was a major finding in the paper. Now, ellipses could have fit from C2 to C7 depending on how you rotated or orientated them in space and depending on how you changed their B over A ratio. So we concluded this. If we include T1, the circle is the only geometric shape that accurately models the cervical curve along the posterior vertebral body margins. And we could model chronic and acute pain as well as normal subjects. It was the radius of curve and its height over length ratio that was different between the groups. Okay, so then what we did is we looked at something that we looked at last week. I'm very proud to say this. In chiropractic and in healthcare in general, when we talk about spine research, our group, Chiropractic BioPhysics nonprofit researchers, under the guidance of Bert Holland and Tad Yannick, we were doing things that other people were not doing at the time. We were using receiver operating characteristic curves to look at true sensitivity and specificity of our cut points between our data. We weren't just looking at the group means. Okay, now the group means, let me back up. This is the group mean back here. The means, my average between my population. I went too far, sorry. Getting a little crazy. I know you're getting kind of going, what are you doing? Here it is. These are my group means. These are statistically significantly different, but it doesn't truly tell you about the spread of the data, and are these numbers accurate enough to discriminate the majority of the sample, especially because the chronic neck pain subjects have a large standard deviation of their measurements. They could have many subjects that are well above this 22-degree cut point, even though their mean value is different. So we have to look at what's called receiver operating characteristic curves. When we look at this tells me whether or not our data is really good. We're looking for, if I have ROC curves that are in the 0.7s and up, this is considered a good dichotomous variable or cut point to discriminate between a normal subject sample and a whatever sample, like chronic pain. So this table right here, results of the receiver operating characteristic curve analysis using radius of curve, ARA, and Cobb angles, right? So let's just look at the area under the curve. Normal versus chronic. Can we use 20 degrees or 22 degrees, whatever it comes out, to discriminate between my subjects? Well, what we found out is 18 degrees is actually the most statistically sensitive and specific cut point between my groups. It has an efficiency of 0.72, sensitivity of 0.46, specificity 0.97, positive predictive value 0.94, negative predictive value 0.65. This one's really good, 0.94. The specificity and predictive value for the positive findings, right? This is do these subjects truly have chronic pain? Are these subjects truly normal, right? This is very good. Here's my average area under the curve using the ARA of 18, 0.75. That's considered good sensitivity and specificity. And then we have 0.78 for the radius of curve. That's really good. That's really good. Cobb angle hits just below the 0.7 mark. It's still moderate. It's not good, but it's moderate. And then normal versus acute, we're good, right? If you look at the averages, we're good here. Here we're moderate here. We're good here. Anything above 0.7 is what we want to see. So the ARA is a better dichotomous variable, and we're happy with it. It has good sensitivity and good specificity. So it says here, the area under the ROC curves for normal versus acute pain range from 0.65 to 0.71, depending on whether you're looking at Cobb angles or the ARA, C2 to C7, or the radius of curve. And then more profoundly, normals versus chronic pain. We have better results for this, 0.69 to 0.78. In other words, this is a good dichotomous variable to discriminate between the groups. This is very close to our paper last week where we found 20 degrees was the best cut point from a sensitivity and specificity point of view. Now we go to a different country, a different study, different data, and we find almost the exact same thing. Instead of 20 degrees, we find 18 degrees. Okay, remember, no one variable can discriminate between all the subjects. So what we have to do is look at what percentages of people does this 18 degrees, discriminate chronic pain from normal subject. And this is damn good. We're pretty proud of this, right? So the idea is this. In this paper, we predetermined that these two necks were already abnormal. Predetermined. We said these are abnormal, hands down. We don't even want them in our population, okay? What we wanted to do with this project is we wanted to see what is a true definition of hypo-lardosis. How much curve is good, and when is it too little curve? This is what we were looking at in this population. And by the way, this is not a subject in our population. I just chose these x-rays for convenience of communication. So here's what our paper did. This paper here shows that you have to have a curve that's circular, that's above 18 degrees. If you're not above 18 degrees, you're in a chronic neck pain group. Now, if you have acute neck pain, if you're under 29 degrees, you have acute neck pain. It had moderate sensitivity and specificity. So if you have acute neck pain, working to get your curve into the 30s is much better. Now, if you have chronic neck pain is a little bit different beast. You better make sure your cervical curve is a smooth geometric shape, close to a circle in its segmental distribution. That means it's relatively uniform in its rate of curve at every segment. And then it must be above 18 degrees. And let's just round that up to 20 like the previous paper found last week. 20 degrees is a cutoff point between chronic and normal subjects. And then these down here, these are abnormal necks. If you have curves like this, you better do something about them. They are not typical normal lordotic curves. This particular project defined what a normal lordosis is. Okay, and that normal lordosis is a smooth geometric shape, should be at least 20 degrees and up if you have chronic pain, and if your acute neck pain, it's got to be above 29. The only ellipse circle that we identified to include the entire cervical spine, including T1, was a circle. And it says ellipse circle here because a circle is a special type of an ellipse. That's actually my dad's writing. He wants you to know that, hey, here's an ellipse. It has a long axis and a short axis. Here's a circle. Its long and short axis are equal. So, you know, you could call a circle a special type of an ellipse where its B/A ratio is 1. It's called a radius. So this is the model for the cervical curve. The cervical lordosis in both acute and chronic neck pain patients is actually hypo-lardotic. It's less than normal subjects. The radius of curve was actually largest in the chronic neck pain subjects, meaning they had the smallest amount of curve, 22 degrees on average, compared to a 34.5 degree curve in normal subjects, where the radius of curve was actually the smallest, right? And I hope that doesn't confuse anybody. The radius of curve is smaller, meaning more curve in normal subjects. The radius of curve is larger, meaning less curve in chronic neck pain subject. So circular modeling was able to accurately discriminate normal lordosis versus hypo-lardosis in subjects with and without cervical cranial symptoms. Now, this statement goes back to our ROC curve analysis. Our radius of curve had the best sensitivity and best specificity. So circular modeling is actually more accurate in its discrimination between pain and non-pain groups. That should make sense. It's a more sophisticated analysis than just simply looking at two lines and an angle. You have to physically model the shape of their spine and then look at the radius of that curve. And if our subjects are matched for height, then we can accurately do this. This is one of the most profound statements in this paper, and it's often overlooked because people don't realize there's different levels of evidence. There's hierarchies. This is a much more sophisticated approach, right? Just because one measurement of curve in your neck may not be different, that doesn't mean that the shape of your neck curve is not different. Therefore, circular modeling is very important if you could do it, right? The normal group circular model and radiographic values, therefore, should be used by, it says can, I'm going to say should be used by clinicians and researchers as goals of care in both surgical and conservative rehabilitation treatment strategies and techniques. And that was one of the goals for doing this project. We want to have robust information to say, hey, patient, we've identified a problem on your spine x-ray of your neck. In this case, this can contribute or cause your chronic neck pain or your chronic whatever. In this case, chronic neck pain. You have a value of curvature that's less than what it is supposed to be. It is a diagnostic test. It's no different than going and getting blood lab work and your doctor sits you down and he says, hey, you've got an extreme problem here. Your white blood cell count is way off. They compare your lab values to normals. This is the same thing with an x-ray. You should identify a CBP trained chiropractor if you're out there and go to that chiropractor because they're trained to identify abnormal findings on your x-ray. Other providers may not be trained in this same manner. They may go, oh, well, it's normal for you. It's not normal for you. If you watch these videos, having no neck curve is not normal for you. It is not. It's just like being blind is not a normal variation of vision. Just because it occurs, it is not normal for you, right? Would you rather have vision or would you rather be blind? Which one? Now, obviously, you can't change vision. We can change your neck curve if you go to a CBP trained doctor. That's my point here. Go to somebody that's skilled and trained in identifying these things. They can also help to correct them and help to improve your condition. Hopefully, you enjoyed this video. Until next time, Dr. Deed Harrison, thank you for your time and attention.